in part because it's next to the.
What is the definition of the labyrinthine part?
Yeah, I'm not sure.
So if you see this, you are absolutely right that this is the facial nerve canal, but facial nerve has got various parts around the temporal bone or around the medullary cavity. And my idea of learning temporal bone is around nerve. So if you know your facial nerve, around that knowledge, you build your concepts. This is the tympanic portion of the facial nerve. If you see here, this is the medullary cavity. This is the epitympanum. This is the malleus. This is the incus. This part is here. Now, what is this part? What is this? Candidate one?
Yes, if that's the tympanic part, so
No.
is this
So
one?
tympanic part is this one. There is something else which is just superior to this level. Of course, on an axial slice, you are seeing a bit of partial voluming here. So my question is, this tympanic, let me ask you in different, direct words. The tympanic portion of facial nerve passes underneath this structure. This is a hint. And
okay,
what
that's the semicircular canal, but it's the lateral one, the lateral semicircular canal.
Excellent, excellent, well done. Okay. Now, these are the two owls, eyes of the owl, right? Just like your case, cholesteatoma case, which you saw. This is the medial, this is the lateral. What is this? What is this? Over to you. This is the same question which I asked in that, your cholesteatoma case.
Yeah, so then that has to be the facial nerve.
So name the parts. Hint is,
yes, the parts that I need to name.
So this part one here is the same part which you saw here.
Okay, the tympanic. Okay.
So this is the tympanic part. What is this part?
Is that then the labyrinthine part?
Excellent. So that is the labyrinthine. So we'll come back to this. This is the labyrinthine portion, and this is the tympanic portion. Okay, so let's go back. Now, overview of the skull. Now, this bone, this red bone, of course, these are various bones of the skull. We are interested in the temporal bone. Now, the temporal bone has got 5 different portions, technically speaking. This part is the squamous temporal bone, squamous part of temporal bone. It forms part of the middle cranial, floor of the middle cranial fossa. What is this? This groove, candidate one?
The groove for the middle meningeal artery.
Excellent. So this is the middle meningeal artery. And interestingly, out of the bones of the skull, squamous temporal bone is the thinnest portion. And this is very dangerous because if somebody gets a trauma here, there can be an epidural hematoma because of middle meningeal artery rupture. Now, on the other hand, another part of temporal bone is the petrous part of temporal bone, which is our main area of interest. And this is the densest bone in the human body, remember. So coming back, I was telling you that there are 5 parts of temporal bone. Squamous part, mastoid part, tympanic part, styloid, and the petrous part. So out of these parts, we are most interested today in the petrous part of the temporal bone. Now, from here, let's go to the concept of base of skull. Now, base of skull, by the way, is going to be our curriculum next time. But you have to have an overall concept. So without going into details, let's see the base of skull, beautifully seen on this diagram. Base of skull is made up of 5 bones. Out of these 5 bones, three are single bones. These are midline single bones, and two are paired bones. Paired bones include the frontal bone and the temporal bone. Now, the midline single bones include the ethmoid, and then the sphenoid, and then the occipital bone. Now, the sphenoid bone has got various parts. First is basisphenoid, and we are interested there because this is the portion which touches the petrous apex, and there is a synchondrosis there. So the basisphenoid is part of the sphenoid bone, which is midline, and all of your pituitary fossa, you know, the sella, the anterior clinoid processes, the posterior clinoid processes, the sphenoid sinus, etc., is within this part of the sphenoid bone. We'll cover it next time. This is the lesser wing of sphenoid, and this is the greater wing of sphenoid. Again, we'll cover it next time. We are more interested here. So here in the midline, the basisphenoid forms a joint here at the clivus, and there is a joint here also. And so part of the clivus is made up of sphenoid bone, and part of it is made up of the occipital bone. So these are, you know, the occipital bone has got various parts, which include, you know, other than the clivus, the condylar process, and squamous part, etc. We are not interested in detail. Now, if you see here, the petrous temporal bone forms a synchondrosis, and in this synchondrosis, it is joining the occipital bone, and it is joining the sphenoid bone. So there is a joint here. This foramen here is known as foramen lacerum, and foramen lacerum, by the way, in a alive person, you know, it is filled up of cartilage, etc. The carotid artery, internal carotid artery passes superior to that. So it passes here, and here is the cavernous sinus. It is hidden within this petrous temporal bone in the carotid canal. It passes like this, and then it goes here into the cavernous sinus. So coming back to the petrous temporal bone. Now you have to concentrate what I am, so this is our main subject today. Now the petrous temporal bone is pyramidal shape. So there is an anterior border, there is a posterior border, and there is an inferior, should I say anterior surface, posterior surface, and inferior surface. There are various foramen. And one of the foramen is this one. This is the internal auditory canal. In the internal auditory canal, the 7th and 8th nerve, they will pass through it. But there are so many other things which are passing through the petrous temporal bone. We have just covered that the internal carotid artery passes through it, through a canal, which call it the carotid canal. And then the facial nerve has to pass into the parotid gland through it. So there is a stylomastoid foramen also. Now, candidate 1, what is this foramen?
That one below the lacerum.
So lacerum was here.
Yes, lacerum.
And nothing of interest passes through, as I was telling you. In a cadaver, it looks like this. Otherwise, there, you know, for us, there is nothing important passes through it. What is this? This is very, very important. Hint.
This is the jugular foramen.
Excellent. So key concept is, please remember, and it's an anatomy question, and it is a true and false type of, you know, the question will be that the jugular foramen is a foramen in the occipital bone, and the answer is false. And another MCQ, jugular foramen is a foramen in the temporal bone, and again the answer is false. Please remember, it is a foramen in between the two bones. So this is the occipital bone, and this is the temporal bone. And this is a hugely important, anatomical landmark for radiologists, jugular foramen. Jugular foramen, even here, you can see that it has got two portions. This one is known as pars nervosa, and this is known as pars vascularis. You don't have to learn this, but it's a good idea because you will not then get confused when you see it on a CT scan. The contents which pass through the jugular foramen, as the name tells you, is internal jugular vein. But with that, there are three nerves: ninth nerve, 10th nerve, and 11th nerve. Now, the name here is pars nervosa, telling you as if nerves are passing through it. Having said that, only ninth nerve passes through it. 10 and 11, they pass with the internal jugular vein in this pars vascularis. So you don't have to remember it, but it's a good idea to see that, this will be the sort of a shape, and we will cover it on a CT scan. So this is the jugular foramen. Now, this thing here, if you see, is known as arcuate eminence. This is a thick part which makes the superior most portion. It is superior to the superior semicircular canal. So these were, let's take it further. Now, if you see here, this is your clivus. As I was telling you, that clivus is made up of two bones. One is the occipital bone, and this is the basisphenoid or the sphenoid bone. In a growing skeleton, there will be a synchondrosis there. There will be a joint, and this shows on a CT scan. So don't get confused. If you are doing an on-call report and of a trauma, child, don't get confused that this is a fracture line. And on an MR, don't get confused. So this is the basisphenoid. This is the basi-occipit, which is part of the occipital bone, and this is known as the spheno-occipital synchondrosis. And in an adult, it will become just one bone. Now, look at these nerves, and these nerves is a repetition. And part of today's talk is repetition, 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 and this is what I told you in the beginning. So if you see here, this is the occipital bone, and this is the petrous temporal bone. This is the internal auditory canal, where the 7th and 8th nerves are going into the temporal bone. This is the jugular foramen, and this is the 9th nerve. This is 10th and 11th nerve. And look at the shape. So this is the pars nervosa. This is the pars vascularis. So on this side, it is clearly seen. This is how the jugular foramen will look like. Now, another thing is that at this level, at the level of pons, there are other nerves which are coming out. So two nerves are going into the temporal bone. These are the 7th and 8th nerves. But anteriorly, there is a 6th nerve. Look here. It's a skin nerve. So you can see it on an MR, but you have to look at it carefully. Now, this nerve passes through the sphenoid portion, this basisphenoid, and then it goes into the cavernous sinus. And I'll show you a case, which is an exam case, petrous epicitis, where there is inflammation or infection at the petrous apex. And it can cause, you can see the anatomy here, that this is the region. It can affect this nerve, which is the 6th nerve. 6th nerve passes into the cavernous sinus, and then it supplies the lateral, muscle, extraocular muscle, lateral rectus. So the patient will present with palsy of this lateral rectus. Of course, in the cavernous sinus, other nerves are also passing through, and it will cause involvement of those nerves also. Same thing, if there is infection here, can cause other things like, cavernous sinus thrombosis. So this anatomy is the key. So we'll see it as the last case of the day later today. Now, this is the 6th nerve, and slightly more superiorly, the fifth nerve is going anteriorly. This is the trigeminal nerve. It is a big, thick nerve, and we can see it very well on a CIS MRI scan. It goes into this part, which is known as Meckel's cave, very well seen on an MR, and it divides into three branches. V1, which is the ophthalmic branch, and then the maxillary branch, V2 and V3. V1 and V2, remember, they go into the cavernous sinus. V3 is favorite in the exam because it goes through the foramen ovale and goes into the masticator space. And I'm going to show you a case today of perineural spread. So this is the anatomy. So I repeat, fifth nerve, which goes into the Meckel's cave, two branches, V1 and V2 goes into the cavernous sinus. V3 goes through the foramen ovale into the masticator space. Now, sixth nerve passes through the sphenoid bone and goes into the cavernous sinus, and of course goes into the orbital. Seventh and eighth nerves, they go into the internal auditory canal. And ninth, 10th, and 11th, they go into the jugular foramen. 12th nerve, we'll this is hypoglossal canal, we'll cover it next time. So these are the nerves of interest today. And just to make a point, repetition, that these are the nerves which pass through the cavernous sinus. Of course, oculomotor and the third nerve, third and fourth, we did not mention because they come out at the midbrain level. Then, of course, the V1 and V2 and V6. Sorry, not V6, the sixth nerve, should I say. Now, just concentrate on what happens with the carotid artery. Now, carotid artery is coming through the neck. It is the content of the carotid space. It goes into the petrous temporal bone, the pyramid. And if you see here, it travels through it vertically, and we will see it on a CT scan now shortly. You can see this, it is going vertically. This is known as vertical portion. And then there is a horizontal portion in the carotid canal. And then it passes, look at this, it passes it passes on top of the foramen lacerum. And then it goes into the cavernous sinus. So you remember that this is where it is passing through the cavernous sinus. Okay, so candidate 1, anatomy question. What is this? Which foramen is this? Candidate 1.
Sorry, I was trying to unmute myself. That's the jugular foramen.
And what is this?
And that's the anterior to jugular is that's the carotid canal.
Excellent, well done.
Yes, medial continues medially as well.
Yeah, so this is the carotid canal and this is the jugular foramen. And now, same thing here, next slice, you can see here, this was the vertical portion and then it has turned into the horizontal portion, and the jugular foramen is still visible here. Now, candidate 1, what is this? What is this? It's a bit harsh because there is a bit of partial voluming, but there is a canal here. So what is this?
It's not continuation still of the carotid canal, no?
Yeah. So this is the carotid canal, and this carotid canal is the horizontal portion of the carotid canal. Now, what is this where my arrow is? What is this?
This is the apex of the...
Excellent. So this is the petrous apex.
Petrous apex, yeah.
Now, petrous apex, please remember, in various people can have various kind of appearance because it can be pneumotized. So if you see here, these are mastoid air cells which has got air inside. So these can be also in our patient, there are no air cells, but in many patients you will see that there are air cells and you should not be confused about it. So let me show you a DICOM, CTA and CTV, and the aim is just to show you, just one second. Can you see my DICOM viewer?
Yes, I can.
Okay, so let's go through this anatomy once again. Now, this is, let me put in a sagittal there instead of a coronal. Now, our aim is, let me change the window here to bone window. Now, our aim is just to see the vessels through the carotid canal. Now, can you see my mouse, candidate one?
Yes, I can.
Okay, so if you see here, this is the common carotid artery. Now we are going up in the neck, and it divides into external carotid and the internal carotid. Now we are going to follow the internal carotid and see how it goes into the carotid canal. So this is the internal carotid. Let me trace it backwards. So this is the internal carotid artery. And we are, even here, if you see here, this is the carotid artery and this is the jugular vein. And everything here is together is in the carotid space. And now this carotid artery, internal carotid artery, goes superiorly and it is touching the base of skull. And here, this is the vertical portion where you see this thing, you can see it as a cross section, because this is the vertical portion as we had described of the carotid canal. Now you will see it will become horizontal. Now it has become horizontal. It is passing through the petrous part. Here, you know it is passing superior to the level of the foramen lacerum. And here, it is going into the cavernous portion, cavernous sinus. And of course, then there is supraclinoid portion. That's not part of our mandate today. We are just interested in the carotid canal. Now, let's see the jugular foramen. So I am now, if you see here, I am going superiorly. So you can see that this is the superior sagittal sinus. And so this is the superior sagittal sinus. And we are coming inferiorly. This is the superior sagittal sinus. And then it divides into the transverse sinus. Now it goes here. This is the sigmoid notch. And then it passes down. And now it has to come out. So it will come out through the jugular foramen. And it then passes into the neck. And here, this is the carotid space where we can see it. One point to remember here is that when we will cover carotid temporal bone or the middle ear, the middle ear cavity, just remember that jugular foramen or is inferior to the level of the middle ear cavity. So it indirectly forms the floor. But there are normal variants in which it will be at a slightly higher level. If you see here, you can see that this is the head of the malleus and incus, and this is the internal auditory canal. So I am going inferiorly, and now you don't see it. And then you see the jugular foramen. Key point to remember that it makes the floor, but as a normal variant, at times it can be what we call high riding jugular foramen. Now, on the other hand, the carotid artery is anterior to the middle ear cavity. So these 2 points are important for you to remember. So this is the middle ear cavity, and the carotid canal is anterior. There are normal variants in which this bone will be dehiscent and the internal carotid artery can project into the middle ear cavity. Similarly, in high riding jugular foramen, the internal jugular vein can project into the middle ear cavity. We call it high riding dehiscent uh, jugular foramen. But these are normal variants. Otherwise, normally, key point to remember, jugular foramen will be the floor and the carotid canal will be the anterior wall of the middle ear cavity. Okay, what we will do is that we will take a 5-minute break and we will rejoin after 5 minutes. So after the break, it will be candidate 2. Thank you, candidate 1. Now, if you see here, this is the facial nerve. It's a schematic diagram, but it tells you everything. This is the pons, and this is the facial nerve. It comes out. This portion of the facial nerve passes through the CP cistern, the cerebropontine angle cister. Then it passes into the internal auditory canal and then into the temporal bone. This portion where I am pointing out is the labyrinthine portion of the facial nerve. It passes anteriorly, and this thickening is known as the geniculate ganglion. So this is the geniculate ganglion. And from here, it turns on itself and passes posteriorly. This is the tympanic portion. And this is also known as the anterior genu. And as it passes through, this is somewhere here is the posterior genu, and then it passes vertically down. This is known as the mastoid portion. So I repeat, this is the labyrinthine portion, the geniculate ganglion or the anterior genu, the tympanic portion, and then the mastoid portion or the descending portion. You can imagine that the parotid gland will be sitting here. It will pass into the parotid gland, and then it will divide into terminal branches. One branch of interest goes anteriorly from the geniculate ganglion, and this is the greater superficial petrosal nerve. It supplies the the lacrimation, so it controls the lacrimation, and it also supplies the sublingual and submandibular glands. So on this axial, now this axial is key for you because all of this anatomy can be seen on partly CT scan and partly MR. So this is an axial slice where it comes out. So this is the facial nerve. It comes out, and so it passes through the CP angle, then goes into the internal auditory canal, and then it passes superior to the cochlea. So the cochlea, of course, is inferior to it. It passes on top of it. This is the labyrinthine portion. This is the lateral geniculate ganglion, or the geniculate ganglion. And then this is the tympanic portion. Now the tympanic portion will pass inferior to the lateral semicircular canal, and then it will descend down, the descending portion. And here the greater superficial petrosal nerve is shown to be going anteriorly. Now here you can imagine that it rises at a higher level than the eighth nerve. So it is superior to the cochlea. On the other hand, this is the cochlea, and the cochlear nerve comes out of the cochlea. This is the vestibule. Vestibule has got various components, including saccule and utricle. You don't have to remember intricate details for FRCR, but you should know that there are semicircular canals. This is the superior semicircular canal. This is the lateral semicircular canal. This is the posterior semicircular canal. This is the endolymphatic duct and the sac. Now, this is a potential exam scenario where, because we can see it on an MR, and we can see it on a sagittal sequence of MR. Within the lateralmost part of the internal auditory canal, actually there are 4 nerves. And as I was telling you, they can be seen on an MR, and this has been asked in the examination. There are 4 nerves. Anterior superior quadrant is the facial nerve, common sense, because it is at a higher level. So this is facial nerve. Anterior inferior quadrant is the cochlear nerve. It comes out from the cochlea. Sorry. And Then there is superior and inferior vestibular nerve. These will join together. So candidate 2, name this nerve. You can't unmute. Okay, let me help you.
Yeah, so that's the facial nerves.
Right. Which is this nerve? So candidate, okay, what we can do is, candidate 1, you are already a co-host as far as I am concerned. And I think there is a technicality. Try it again.
Yes, so now it's possible.
Okay, so what is this nerve?
That's the 8th nerve.
Which nerve? Name the name.
Vestibulocochlear nerve.
No, my question is, you see, this is the lateral most portion, and you are seeing 4 nerves. Which one is this?
Vestibular nerve.
This is the inferior vestibular nerve. That is the answer. If you see here, this is the superior vestibular nerve. This is the inferior vestibular nerve. The formula here is 7 up, which is the 7th, and coke down. So this is the cochlear. Superior vestibular, inferior vestibular. So these 4 will be seen on a cis-sagittal sequence, and this has been shown in the exam just like this. This is a coronal, sagittal oblique type of a sequence. 7th nerve, cochlear nerve, superior vestibular, inferior vestibular. What happens is that they join together to form the vestibular nerve, and then they join the cochlear nerve to form the vestibulocochlear nerve. So this is posterior because this is cerebellum posteriorly. Now, so just a repetition of what we have already learned. This is the labyrinthine portion, geniculate ganglion, greater superficial petrosal nerve, tympanic portion, and the descending or mastoid portion. And you can see how it goes into the parotid gland and then gives the terminal branches. Now, we have learned one branch coming out here. There are other nerves. One of the nerves is this nerve. There is a muscle here, which is known as stapedius muscle within the middle ear cavity. And this joins the stapes. It causes what we call sound damping. And there is a nerve which provides, there is a branch which provides innervation to this. This is the nerve to the stapedius. There is another nerve here, which is known as cauda tympani, which actually on a CT scan, you can see it on a sagittal sequence. It comes out and passes through. Cauda tympani supplies, what is the candidate to? Cauda tympani. What do you know about it?
So it's the tongue.
Yeah, good.
Posterior 2/3 of the tongue.
Anterior
It supplies,
2/3.
yes, sir, it supplies anterior 2/3 of the tongue.
There is a confusion. There are 2 candidate 2s who are speaking. So, Azhar, if you are listening, can you sort that out? Who is candidate 2? Because there are 2 candidates 2 who are speaking. Now, so this is cauda tympani, and this is part of the function of the facial nerve, anterior 2/3. So from here, what we can learn? We can learn that there are various functions of the facial nerve. Clinically speaking, we can see.
Sir, it supplies. Sir, the chorda tympani nerve supplies anterior two-thirds of the tongue taste receptor.
Madam, there is, excuse me, there, I think there is a lag or something because I was not asking you. Can you mute yourself? Because right now we are in another, I'm asking the question to another candidate, and I believe there is a confusion. Two people have sort of registered as candidate twos on the system. Okay, Azhar, if you can text them and sort this out, who is candidate 2 and who is candidate 3 or 4. Now, this is chorda tympani, and so various functions of the facial nerve include lacrimation, which is controlled from here, sound dampening, which is controlled from here, anterior two-thirds of the taste, and then there is what we call muscles of facial expressions, which are controlled from the distalmost branches. Okay, now we go from here. One of the main parts of anatomy where we are going to learn on this one. If you see here, candidate 2, can you hear me?
Yes, sir.
Okay. So here, part of the exercise is that we are going to develop our concept about the facial nerve. So what I do is when I am reporting a temporal bone, to orient myself, I see the cochlea. So I call the cochlea the flower. This is the flower. It is a very prominent structure. And of course, cochlea will be at the level of the cochlear nerve. So here will be the internal auditory canal. Now, as I'm going superior to the level of the cochlea, so once again I go inferior. Which we are doing right now is to trace the facial nerve. This is the cochlea. I'm going superior to that. And you can see that there is a canal here, and this is the labyrinthine portion. And it goes here, and this must be the geniculate ganglion. And then you can see that something goes posteriorly. This is the tympanic portion. It is going posteriorly. Just concentrate on this, where my mouse is. This is now we are going posteriorly, and it is now going to descend down. So it is descending down, and I am going inferiorly where the arrow is, and ultimately it goes into the stylomastoid foramen and then goes into the parotid. You can imagine that the parotid gland must be sitting here. So this is, let's track it once again, the facial nerve. So this is the cochlea. We go superior to the level of the cochlea, and we can see that nerve is coming from the internal auditory canal, going anteriorly, and then the tympanic portion goes posteriorly, and then it becomes a ring because we are seeing it end on. It is descending down, and ultimately it goes out. Let's see a few landmarks surrounding it, but we will not overwhelm ourselves. Cochlea, of course, is a landmark. We go superiorly. Now, here is the lateral semicircular canal. And on this side is the medullary cavity, the head of the malleus and the incus. This is what we call epitympanum. And you can see this hourglass appearance. This is known as editus ad antrum. This is the epitympanum. This is known as editus ad antrum. And this is the mastoid antrum. And these are the mastoidal cells. So coming back to landmark is this lateral semicircular canal. And the tympanic portion, it passes inferior to that. We will see it very well on a coronal section. Now we are going inferiorly. So here, if you see it very carefully, you can see a triangular structure where I am pointing out. This is known as, actually you can see it here very well where I'm pointing out. You see this? And this is known as pyramidal eminence. We will learn about it subsequently. If you see it very carefully, there is a dot here. So this is the stapedius muscle actually. And this thing is the descending portion, and it will go out. Another point to remember is that, okay, so what we do is that we go to the coronal section. So, and again, first of all, let's orient ourselves. So, if you see here, this is the internal auditory canal. Now, this is a good point to, it's a very, very powerful landmark here, that this is the lateral semicircular canal, this is the superior semicircular canal, this is the internal auditory canal. Now, I am going posteriorly, and you can see that this is the cochlea. So here are two dots, and these are the dots which I showed you initially. So let's trace it backwards. This is the internal auditory canal, and you can see something entering here. So this is the dot which is superior to the cochlea. This is the labyrinthine portion of the facial nerve. And now it goes anteriorly, and here it becomes one. You see, these are two dots. I go anteriorly and it becomes one. Why? Because this is the geniculate ganglion. And from the geniculate ganglion, I am going backwards once again, and you can see the two dots. This is the tympanic portion of the facial nerve. It will pass below the lateral semicircular canal. And here it is. And you can see that this is lateral semicircular canal, and this is the facial nerve. This section is a very important, this cut for your exam, because if you see, this is the lateral semicircular canal, and there is bone here, and this is air here. In cholesteatomas, what can happen? A cholesteatoma will be sitting here. It will erode this portion, and then there we will call it fistulization of the lateral semicircular canal. And fistulization of lateral semicircular canal can cause a lot of symptoms, and they show it in the exam. You have to learn how to diagnose it on an axial and also on a coronal. Now this is the tympanic portion, and we will see we are going posteriorly, and we are expecting it to dip down vertically. And you, on a coronal, you will see it very well. You see this thing? It goes vertically down like this. And you can imagine that this is the stylomastoid foramen, and here will be the parotid gland. Now, if you see the relationships, here is the epitympanum, this is the sputum, this is the external auditory canal. So now let's go for a sagittal. Sagittal will show you the descending portion very well. So otherwise, there is not much value to the sagittal. So these are the mastoid hair cells, and you can see here you are. We call it the hockey stick appearance. This is the descending portion. This is the stylomastoid foramen. Many a times you can actually, if you see carefully, this, you see this thing. This is the chorda tympani. It is slightly off center. So here you are. You see this thing. This is the chorda tympani. Then it will pass through the middle ear cavity and supply the what we call ultimately anterior 2/3 of the tongue. We will come back to this. So right now, our aim was just to develop our eyes on the facial nerve. So Okay, candidate 2, can you see my diagram? This is external ear and middle ear.
Yes.
Okay, now with this background, we have to develop, and there will be repetitions as I was telling you. Now, if you see here, this is the external auditory canal. It has got a cartilaginous component and it has got a tympanic, a bony component. This is the tympanic membrane. Superiorly, tympanic membrane is attached to this part, which is known as sputum, and inferiorly to the tympanic annulus. This sputum is an exam thing. I showed candidate 1 this thing. This part here, where I am pointing out, this air here is known as Prozac space. And there are 2 types of cholesteatomas. One of them is known as sparse placida cholesteatoma, which is the most common site. The cholesteatomas occur at this site, and they cause erosion of this sputum. So that is one of the key things to remember. Now, coming back to this anatomy, this is the tympanic membrane, this is the inner ear, and this is the middle ear. Now we have to concentrate on the middle ear. But look at the surrounding structures. This is the internal auditory canal, and the nerves are coming in. This is the lateral semicircular canal, the superior semicircular canal, the vestibule, and part of the cochlea. Now look at it. These are the ossicles, the malleus, the incus, and the stapes. Now look here, same thing, but a bit of a close-up here. Now this is malleus, incus, and then this is stapes. This part is known as epitympanum. This is known as mesotympanum. This is known as hypotympanum. Now, if you see superiorly, this is the roof, which is known as tegmen tympani. Tegmen tympani. Now, various portions of the ossicles. So, these are the ossicles. This portion, you don't have to remember everything. You just have to remember that the malleus is attached to the tympanic membrane. But the head of the malleus is here. It is in the epitympanum. Head of the malleus is an exam thing because they will show you cases of incudomalleolar dislocation. So this will be a head trauma case in which there will be an incidental finding of a fracture of the temporal bone and maybe incudomalleolar dislocation. I'll show you. So this is the head of the malleus. It joins the body of the incus. Then there is a short process of incus and there is a long process. And this long process then joins to the stapes. The stapes has got anterior crus and a posterior crus. This is the foot plate which joins the oval window. Now, if you see here, a repetition, this is the stapes, and the capability of CT scan now is that, stapes is the smallest bone in the human body. Anterior crus is 0.58 millimeter, posterior crus is 0.6 millimeter, and we can actually see it on a CT scan. And we can see actually the joint also. So, with this background, this is a key diagram. Now you have to really concentrate, and part of it is going to be repetition. And this is the main diagram on which you have to concentrate. Now, you are sitting in this. This is the middle ear cavity. On this side is the external ear. On this side is the internal ear. Now, there are various walls. So this is the lateral wall. This is the medial wall. Posteriorly is the posterior wall. We are looking through the anterior wall. Just remember that anteriorly, the structure which you should remember is the carotid canal. So carotid canal is anteriorly. Now inferiorly will be the jugular foramen. Superiorly is the tegmen tympani, and then the brain. You see this thing? So this is segment tympani, brain there. Inferiorly, jugular foramen. Lateral, external ear. Medial is the internal ear. Posteriorly, we are going to learn, because posterior will be the mastoid. And anteriorly, remember that the jugular correction, the carotid canal will be there. Now, concentrate on the medial wall. The medial wall is critical. Now, our friend is the facial nerve. Okay, before I go to the facial nerve, one thing which I want you to concentrate on is you divide the middle ear cavity into 3 stories. So this is the attic, and this is the, the main room, and then is the basement. How do you divide it? Now, this is the tympanic membrane. If you draw a line, imaginary line, from here to the tympanic portion of the facial nerve, here, superior to that, and the lateral semicircular canal will also be at times at the same level. Superior to that will be the epitympanum. This is the mesotympanum, also known as the middle ear cavity proper. And this is known as hypotympanum. Hypotympanum is nothing. It is just empty, just a trough in the floor, nothing more than that. So don't worry about it. Just remember that below the hypotympanum will be the jugular foramen. Now, so this is mesotympanum, epitympanum, and hypotympanum, which is not important. Now, this is the facial nerve canal. Now, this is passing backwards, and this is the lateral semicircular canal. Here, what is happening, that this is the cochlea, and there is a bulge here, which is known as cochlear promontory. Coming back to the ossicles, if you see, this is the handle of the malleus, but the head is sitting here. So the head is in the epitympanum, and the handle is in the mesotympanum. Here, it joins the body of the incus. And there is a short process and there is a long process. Now, long process tips down once again into the mesotympanum. And here it makes this joint with the stapes, which is joined with the oval window. If you see here, now concentrate on the posterior wall. So we are looking at the posterior wall. There is a hole here. This hole is the additus ad antrum. And on the other side of the hole will be the mastoid antrum. Slightly more inferiorly, the landmarks on the posterior wall include this thing. This is known as pyramidal eminence. And this pyramidal eminence can be seen on axial CT scan. Remember, the descending facial nerve will be next to it. This portion here, which is medial to the pyramidal eminence, is known as sinus tympani. And I will show you on a CT scan. So this is the main, concept to remember. Now, once again, we are looking at the medial wall. So this is the promontory. This is the facial nerve canal. This is the lateral semicircular canal. And from here, a bit about the internal ear. So I'm not at all going to go into the details of internal ear, which is beyond our curriculum. But please remember that internal ear has got an exoskeleton, which is bony. We call it the bony labyrinth. And inside is fluid containing structure, which is known as membranous labyrinth. Some of the names are common. So for example, cochlea and vestibule. So there will be a bony labyrinth or an exoskeleton and an internal skeleton which has got fluid. So the fluid will be well seen on MR and the bony component will be well seen on CT scan. So this is cochlea. which has got 2.5 turns. You don't have to go into details. This is the vestibule, which has got utricle and saccule. Don't go into details. Then there is lateral semicircular canal, superior semicircular canal, posterior semicircular canal. You have to remember them, particularly the lateral and the superior. Then there are endolymphatic duct, which is this one, an endolymphatic sac, and there is a cochlear aqueduct also, and a perilymphatic duct. Don't worry about that. So this is a diagram, shows you the microscopic structure of the cochlea and the nerve going in. So this is the flower we are talking about, few MR sections. Now, if you see here, this is the lateral semicircular canal, and this is the flower, which is the cochlea. So, and you can see the nerves here going, the cochlear nerve and the vestibular nerve, as we already know. This is the coronal section, where you can see the superior semicircular canal, the lateral semicircular canal, and the vestibule. So this is the cochlea, and this is that sagittal sequence, which is an exam sequence, as I have told you. Now, with this background, we are going to conclude the anatomy by seeing a cis IAM and then a dicom of the temporal bone. And we will repeat a few things, and this will consolidate everything. So let's go for a cis axial sequence of the IAM. So candidate 2, can you see the cis sequence?
Yes, sir.
Okay, so if you see here, this is a bit of a repetition, nothing much. I'm sure you will, you already know it. This is that flower. And from the flower, which is the cochlea, you can see this nerve going here. If you trace it backwards, it joins these nerves. And on an axial sequence, you cannot make out what is what. You know, the superior vestibular and the inferior, where I'm pointing out. Superior and inferior vestibular, which one is what? But they join together and they make a thicker nerve here, and then it goes into the pons. So this is the vestibulocochlear nerve, which divides into cochlear component and two vestibulars, superior and inferior vestibular nerves. Other than that, you can see that this is the vestibule, and this is the lateral semicircular canal. You see, it will make a circle like this. And something which makes a circle superiorly, so this is making a circle superiorly, will be the superior semicircular canal, and this one is posterior semicircular canal. Let's go to our friend, the facial nerve. And you can see there is a thinner nerve than this one here. And this thing goes. And you can see that the cochlea, this is the cochlea, it is going superior. So the cochlea is no more visible, which makes sense. And then you lose it. And you can see on a CT scan, it is still visible, but on a MR, you don't see it. This is a cis sequence. Now, let's see the fifth nerve and the sixth nerve. So these are the two Meckel's cave. This is pons, and you can see the fifth nerve going in. You can imagine that it is going into the Meckel's cave here. And of course, the V3 will go down into the foramen ovale, and the V2 and V1 will go into the cavernous sinus. Now, if you look very carefully on this, we might be able to see the sixth nerve. Now, sixth nerve has to go anteriorly from the pons. So, if you see here, for example, this thing where I'm pointing out, it goes here. So this is the sixth nerve, which is passing into the sphenoid bone there. Okay, now the final repetition on a DICOM, and then we will see a few viva cases. Candidate 2, can you see a DICOM viewer?
Yes.
Okay, so now what we are going to do, we will slightly make it larger and just concentrate on left side. So if you see here, when you are seeing the temporal bone, my landmark was cochlea. So this is the cochlea. But let's have a more global view now. So if we go back, this is the clivus, and then we have got, this is the internal auditory canal. So this is the cochlea. And as I'm going superiorly, this is, okay, let me make it bigger. This is the labyrinthine portion of the facial nerve. It goes anteriorly and then it descends posteriorly. And it is, so this is the lateral semicircular canal. It is going posteriorly and now it is going to descend down. So we are at the posterior wall. And ultimately it will go out. So we trace it backwards. Now, this is a landmark on the posterior wall of the mesotympanum, where you can see this pyramidal eminence where I'm pointing out. And it will be next to the sputum, which is visible here. This is the descending facial nerve. This portion where I'm pointing out is known as sinus tympani. And sometimes this is a clinical blind spot, because when the surgeon is coming from here, they will not see this thing. And there might be a cholesteatoma sitting there, which we have to point out. So this is the posterior wall. Now, coming back to rest of the middle ear, this is the epitympanum, and this space here is the Prozac space. Head of malleus, body of incus. So this space is the Prozac space. This hourglass appearance is the additus ad antrum, and this is the mastoid antrum. And if we go inferiorly, we go into the mastoid ear cells. On the other hand, on the axial slice, so we can see that this lateral semicircular canal is projecting here. As we go inferiorly, so I'm going into the level of the mesotympanum. And here you can see the pyramidal eminence has come into play. You can see the scutum correction, the stapes here. And you can see the tympanic membrane here. You can see the external auditory canal. And as I go further inferiorly, I am going to go into other structures. So I'm going inferiorly. And here, one area of interest is inferiorly. This is the jugular foramen. So let's see it on once again on this sagittal sequence. And we can see that this is the lateral semicircular canal, and this was the sputum, So superior to the scutum, this is the epitympannum. From here till here is the mesotympanum. Hypotympanum is not important. This bulge here is made of by the cochlea, which is this thing, cochlea. The facial nerve is coming from here. This is the dot, which is the labyrinthine portion, the geniculate ganglion, and then the tympanic portion, which passes underneath the lateral semicircular canal. And this is the descending portion. So, now, other surrounding structures, if you see here, this is the carotid canal. So this is the horizontal portion. If we trace it anteriorly, it will go into the cavernous sinus, which is sitting somewhere here. We are going posteriorly. Now, this is it. And then this is the vertical portion. On the other hand, this is the jugular foramen. So this is the anatomy. And now let's start a bit of viva cases. Oh, just 1 second. Candidate 2, can you see my blue slide?
Yes.
Okay, now this is open for chat. So this is a final repetition. I think I've got 4 slides here. It's a quiz. And this is for you to, everybody can participate. This is open for chat. And I'm going to ask one by one. So, answer number 1, what is this? Good. Number 2. Yeah. Okay. I'll give you the answers in the next slide. Number 3, what is this? Number 3. Excellent. Then number 4. If you see here, just to highlight that this structure is partly aerated. And look at this side. You remember the one which I showed you before did not have air cells. So this is pneumotization. Okay. Number 5, what is this? And then number 6, what is this? So I think all of you got it right, but the answers are in front of your eyes and everything is perfect. Okay, now, sorry, what has happened? So number 1, please. Good. Number 2. Excellent. Number 3. Excellent. Number 4. Number 5. Number 6. Number 7. Number 8. Okay, so there were a few different answers for number 8. And so this, if you see carefully, this is the tympanic membrane. So this is the middle ear cavity. We are just able to see it. Now, all of now, if you see here, this mandibular condyle should be part of your protocol when you see a CT of the head trauma. And many a times it has come in the exam, they will show you an axial CT and mandible condyle is not sitting in this fossa. So there will be dislocation. On an axial CT, very easy to miss. So this should be part of your protocol. Okay. Number one, please. Number one. Number two. Number three. Okay. Number four. Number five. Pyramid. Okay. Let's go through them. I think this is a bit harsh for the simple reason, steppies, for the simple reason that I can understand you don't, it is not projecting very well for you, steppies, and the arrow is slightly off. So it's a bit harsh. So I think I'll disregard that. The point was that the steppies is visible here. And this flower, of course, is cochlea. This thing is the vestibule. Now, this answer, I think there is a typo here. This mastoid air cell should not be here. This is facial nerve. Mastoid, it is the descending. And if somebody has said that there is a pyramid here, so that is fine. But my main point was this black dot, which is the descending. So this is a typo. So disregard that. Apologies for that. Now, last, number one. Number two. Number three. Number four. Number five. So number five is regarding this bone here. And number six is this black space, the ear. The space between this incus and the bone. And number seven is this this structure. This, which is projecting here. Yeah, this is a bit harsh because there is a bit of partial voluming. So this is, this is the tympanic portion and there is a partial voluming. This is the lateral semicircular canal. But I do accept that this is a bit harsh. Prozac space out of the malleus and part of the cochlea. If you have mentioned the turn, it is fine. This is the internal ear. This is the vestibule. Right. So on a coronal, this one. What is number one? And number two? Labyrinthine facial nerve. And number three? Tympanic facial nerve. And this one is the bone, and this is that space, this black space. Excellent. So these are the answers. All of you got it right. So, I have Sorry, I think I've already shown you the answers. Let's do it in any case. So number 1, number 2, three, 4, 5. So this is the vestibule, the superior semicircular canal, the lateral semicircular canal, the tympanic portion of the facial nerve. A bit of repetition here. So I think this is easy, where we have got the vestibule, the superior semicircular canal, the lateral semicircular canal, and the tympanic portion of the facial nerve. Okay, last section, coronal. Number 1, number 2, these are harsh because you just see them partially, but you can imagine something going superiorly, you can imagine something going laterally. And then you can see that something is going inferiorly. And then this thing here, number 4. Yeah, very good. So these are excellent. A sagittal sequence. So what is number 1? Good. And what is number 4? Number 4, please. Excellent. So that is the stylomastoid foramen and facial nerve. Okay, so this was the case when we started. So this is the scutum which is eroded. There is soft tissue opacification which is involving the epitympanum as well as the mesotympanum. This is the tympanic portion of the facial nerve. This is the labyrinthine. Nothing is happening there. On this slice, we don't see the lateral semicircular canal, but we can commit that the tegment tympani is not eroded. So this ossicle maybe looks slightly attenuated, maybe slightly attenuated. So this was just to develop anatomy. Now we will take 5-minute break, and then we will see few in the last hour. We are going to see viva cases of the temporal bone. Candidate 2, you are with us?
Yes, sir.
Okay. So now we are going to see a few viva cases in the last 1 hour. First thing is cholesteatoma. Now, let me tell you a few theoretical points about cholesteatoma before we see the cases. Basically, what is happening in a cholesteatoma that so this is from Chapman. Cholesteatomas, of course, can be congenital and they can be acquired. We are talking about acquired cholesteatoma here. And the classical location includes pars flaccida, which is 80%, pars pensa is 20%. Candidate 2, you can see my slide, Chapman's slide.
Yes, sir.
Okay. Now, you have to remember the pathology, what is happening. Basically, in cholesteatoma, you see here that because of otitis media, there is retraction membrane and the skin cells, they go into the medullary cavity. And you remember that one of the properties of the skin cells is exfoliation. So they keep growing and they have got keratin inside. That becomes a ball and that ball keeps growing. And this keratin has got some properties of absorbing the bone. It takes years and years to develop, but gradually it will destroy the structures. Key finding on a CT scan are two. One is that non-dependent opacity with bony destruction. Where and how the bony destruction will be, we will see. But how good are we on a CT scan to diagnose cholesteatoma? Our sensitivity and specificity is not very good, which is obvious. But these are the two key points which we remember. And you see, this is the concept, focal accumulation of exfoliated keratin within stratified squamous epithelium. CT scan, you know, this will not enhance either on CT scan or on MR. Surrounding granulation tissue can enhance. Key point to remember is that cholesteatoma can cause on MR, it will show restricted diffusion. This is key point to remember. Actually, you remember in CNS, we have done epidermoids. Now, histologically speaking, epidermoid is the same thing as cholesteatoma. The only thing is that when it is within the intracranial cavity, we call it an epidermoid, which is when it is in the scalarium, we call it an epidermoid. But in the temporal bone, we call it a cholesteatoma. We have made life, uneasy for ourselves, difficult for ourselves. But remember that it will show restricted diffusion. So with that background, if you see this picture here, what is happening? This is a classical cholesteatoma, which is at the Prozac space. This is partial cholesteatoma. So if you are an ENT specialist and you are doing horoscopy here, you will actually see it. An pearly white type of appearance. And many a times the clinicians, they tell us that I can see a cholesteatoma, please see what is happening inside. Tell me the roadmap, what to do when I'm going in, what to expect. So this is a classical pars flaccida cholesteatoma. And gradually it will erode this scutum. This is in the Prozac space, and it will erode this ossicle. But then there can be pars tensa cholesteatomas also. It can be in other parts of the medullary cavity. They can be very large. Look at this example where it has eaten up everything. And look at this tegment tympani, which is eroded. Lateral semicircular canal is eroded. It can erode the facial nerve canal ossicles are eaten up. So all of these things can happen. So if you see here, pars flaccida, pars mensa cholesteatoma. The main thing to remember is non-opacity with non-dependent opacity with bony destruction. Now look here, candidate 1. If I tell you that this is a cholesteatoma, can you prove me right? Sorry, candidate 2. Can you describe it? What's happening?
There is a soft tissue attenuating lesion in the middle ear cavity abutting the malleus and incus. There is no erosion of the adjacent bone. This is in the dependent portion, so and there's no erosion, so it's unlikely to be a cholesteatoma.
If you see here, it's vice versa actually. The dependent portion is this one, right? This is non-dependent, and this is classical. This is the Prozac space. We are at the level of the epitympanum. This is the head of the malleus, and this is the incus. And this thing is eroding it. This is a classical pars flaccida cholesteatoma, exam cholesteatoma on an axial slice. On the other hand, this is a non-dependent opacity. If you can see, because automastoiditis, acute over chronic mastoiditis can also cause bony destruction. But if you see, there is a fluid level here, and this is a non-dependent cholesteatoma. Non-dependent opacity. Now, so our specificity to say that this is a cholesteatoma is not very good on a CT scan, but here we can be less confident. Here we are more confident. Now look at this case where there is opacity here and there is a bit of erosion of this structure. What is this structure? Candidate 2?
That's the scutum.
You see, we are at the level of lateral semicircular canal. This is the lateral semicircular canal, just like this. And on an axial slice, there is a bit of, erosion. So, so the point is that there can be erosion here. Here in this case, what is happening that there is opacity. Of course, these are harsh cases because I'm just showing you a single slice. Here, there is a complete erosion, just like this case, just like this case. I'm just showing you a particular level, should I say. Now, candidate 3, are you with us?
Yes, I am.
Okay. So, candidate 2, thank you very much.
Thank you, sir.
Okay. Now, these are the features of cholesteatoma which you have to remember. So, which kind of, one is middle ear specification, then erosions. So, what to look for? There can be scutum erosion, as I've told you, ossicular erosion, ossicular displacement can be there. Sometimes there can be expansion of adductus ad antrum, but a favorite of the examiner will be lateral semicircular canal fistula. And you have to really develop your eyes on this. This is an exam scenario because these patients will then present with a lot of balance abnormalities. Please remember that cochlea is involved with, sound as in deafness, etc. And the vestibule and the semicircular canals are involved with balance. So if there is fistulization, the patient will become very symptomatic. And then you have to see, so these should be your pertinent negatives or positives in when you are describing it. Segment tympani, is it eroded? Facial nerve canal, is it dehiscent, etc. So these should be your pertinent negatives. Just describe it for me. This is a case of cholesteatoma, but can you just describe it? Candidate 3.
So thank you. So this is a cone down CT image of the.
Your volume is very low.
Very low.
Again?
I said this is a coned
Yeah,
down.
no, I can hear you loud and clear. Please continue.
Yeah. This is a coned down CT image of the inner ear. In the axial slice, there is a soft tissue density within the inner ear. However, there is no bony erosion of the lateral semicircular canal. It appears intact, no dehiscence in there. And then I'm just looking at the coronal image. The scutum appears to be eroded. Then the tegment tympani appears to be intact. Can't visualize the ossicular chain here.
Okay, very good. Well done. So basically, the exercise is that.
In summary,
excuse me, because of time factor, we'll stop. We'll continue. Let me take over. So well done. So there is a complete opacification of the middle ear cavity. The ossicles are completely destroyed. This scutum erosion is, not very emphatic, but maybe we use a word blunting of scutum. You can use that. And you did well where you ruled out segment tympani. Yeah, that's fine. Good, well done. Now here, this is a known case of cholesteatoma on this side. What is your finding here? What's happening?
I can see that the lateral wall of the lateral semicircular canal has been eroded. So I'd call this lateral semicircular canal dehiscence.
Excellent, well done. So this is a favorite, and you have to develop your eyes. This is what I call the Clint Eastwood sign. This is the old movie 1966, Good, Bad, and Ugly. This is his revolver .357 Magnum, and this is the barrel. This barrel should touch bone. This is the hammer. This is the superior semicircular canal. So this is and this is the vestibule. So this is the vestibule, the superior semicircular canal, and the barrel. This barrel should touch the bone. If it does not touch the bone, as in your case, this is means dehiscence. And you have to develop your eyes to pick it up on an axial also. So on an axial, for example, if you see here, this is dehiscence on a coronal. But on an axial also, you can see it. This is the tympanic portion, and this one here is the lateral semi, which is eroded. Okay, a very big cholesteatoma. What is it doing?
So these are cone down CT images of the inner ear. I think there is an increased density of the bone, sclerosis of the middle ear bone, and the ossicular chain appears to have been disrupted.
This part of anatomy, where are we? Landmark is this. Landmark is this.
So we're in the inner ear.
Yeah. Is the inner ear normal?
No, it's not.
Okay. So the point I wanted you to just see here is that cholesteatomas at times can be so large and so long-standing that you will see cases in which they will destroy even the inner ear. So just wanted to show you an example. This one, I think you have already done. Okay. Now, this is a new world. What is happening here is patient has got right-sided mastoidectomy. And Is there a recurrent cholesteatoma? That is the question. And we have done various sequences. I will tell you why they were done. This is a T2 weighted sequence. This is a T1 post contrast, which has been delayed post contrast, is 45-minute delay. And this is a DWI. So candidate 3, what is your conclusion?
So my conclusion is that there is a soft tissue mass is bright on T2 and doesn't show significant enhancement on post contrast, but is showing some restrictions. So with the conclusion, it's going to be a cholesteatoma because it restricts.
Yeah, so let me now tell you something basic about the role of MR in cholesteatoma. So initially, people used to just do CT scans for cholesteatoma. Then people realized that there is a role of MR. And the initial role in which they started was in recurrent cholesteatoma. So recurrent cholesteatoma is a nightmare on CT. Why? Because recurrent means that it has been already operated. They will do a partial, mastectomy or a, even more extensive type of mastectomies. So there will be just soft tissue visible on CT scan. Is there a recurrent cholesteatoma? And it was a nightmare. So people developed this protocol. In a post-op temporal bone, you can see three types of things can be visible. One is granulation tissue. Second thing is fluid. And the third thing is recurrent cholesteatoma. Now, cholesteatoma will be high signal on T2 weighted sequence, and it will show restricted diffusion. So you did very well where you picked it up. If it was only fluid, it will be high signal on T2, and it will not show restricted diffusion. So granulation tissue can be high signal on T2, but it can show delayed enhancement. Now, because it is sort of granulation means fibrosis. So the protocol was that you give contrast, and because there is not enough vascularity there, you do a delayed post-contrast 45-minute. In conclusion, an MR with this protocol can differentiate between fluid versus recurrent cholesteatoma versus granulation tissue. So there was a time when people used to do this. We have also done in our department. Then we realized that what is the clinical difference of diagnosing a granulation tissue versus fluid, and there is nothing. So people have deleted this sequence, this delayed, and it used to create a lot of administrative issues. 45-minute means you have to, should the patient be on the table, or can somebody else can be scanned and then the patient comes back. So now we are using just DWI, T2s and DWI to diagnose cholesteatoma even in regular cases. So the use of MR has become more prevalent. Initially, it was just in post-surgical cases. Now people are using it. We have also used many a times just to diagnose. So this was one case. Another case, candidate 3 for you. This is post-surgical cholesteatoma, any recurrence. So you can see this T2, this is delayed post-contrast, and this is DWI. Over to you.
So these are coronal images of the brain. Then on the T2 image, it's high signal, post-contrast, can't appreciate much enhancement. Then on the DWI, I can't see any high signal there. So impression here is that this is not a recurrence. It's likely going to be a granulation tissue.
Okay, if you say that there is a subtle enhancement, then your diagnosis will be that this is granulation tissue. On the other hand, if you say that there is no enhancement, then this will be just fluid, and not. But the main clinically important finding you have picked up very well Clinically important finding was that is there a cholesteatoma or not? Please remember, if there is a cholesteatoma, they will go in and they will remove it because it will cause more and more destruction. This is an interesting one. Sorry. Okay, so uh, if you see here, this one did not enhance. This one is showing slight peripheral enhancement. This is so at times this can happen. The surrounding granulation tissue can enhance, but it is showing restricted diffusion. So this is what candidate three?
Cholesteatoma.
Yeah. Now this is bilateral. So I want you to tackle right and left. Let me describe. This is 16-year-old previous bilateral surgeries, any cholesteatoma. First of all, tell us what is happening on the right. Just concentrate on the right, and then I will ask you the left. Over to you.
All right. So the right is high T2 signal, shows some enhancements, but no restriction. So
Conclusion.
this it's granulation tissue on the right.
Excellent. And on the left?
Then on the left, it's high T2 signal and shows no enhancements, but there is diffusion restriction. So that is recurrence of cholesteatoma.
Excellent. Okay. In trauma world, always beware of temporal bone, fractures as well as ossicular dislocations whenever you are reporting a CT scan, particularly in the exam. Please remember, at the level of epitympanum, the head of the malleus sits here with the body. We call it the ice cream cone type of, so it should be sitting here. It is dislocated here. And of course, there is a longitudinal fracture here. I'm not going into details of longitudinal and transverse fractures of the temporal bone and what it can do. But main thing I want to highlight is that always look here to rule out an incubomalleolar dislocation. And if you're doing a Viva case and the examiner might give you half a mark or 1 mark more, look at this example where what is your finding here, candidate 3? Ossicles wise?
Yeah, I think there's also called the malleus and the incus are dissociated. Yes.
Yeah. So incubomalleolar dislocation.
Dislocation.
Yeah. Okay. This case, I have not given you a bone window, so let me talk through it with you. If you see it, and then I'll ask you leading question. So if you see here, this patient had previous history of mastoid surgeries and chronic osteomastoiditis. So you can see a bit of bony defect here. But with contrast, if you can concentrate here, if you can concentrate here, concentrate here, and concentrate here, and let us know what is your conclusion.
So these are still images of the Excel contrast enhanced CT images of the base of the skull and lower parts of the brain. So there is a low density filling defect seen within the sigmoid sinus, and there appears to be bony irregularity and disruption at that area. So I'm just suspicious of a thrombus, but looking externally as well, there appears to be some soft tissue, enhancing soft tissue, external to the region, seen at the upper right image. To me, looks like there's some.
Yeah, this one here.
Yes, some external soft tissue enhancement. I'm not sure what that could be, but the filling defect could represent thrombus. Then looking externally, that one could be due to an infection.
Thrombus where?
Within the sigmoid sinus, there's a low low
Okay,
density
that's fine.
filling defect
That's fine.
there.
Okay, I'll take over. Now, please remember that complications of various kinds of infection is most important case for your exam. And if it is paranasal sinuses, if it is orbit, if it is temporal bone, so because as a general radiologist, you should know that. Now, in this example, what is happening? That there is a lot of, so of course, the windowing is poor, so that is why. But having said that, you can see that there is a soft tissue abscess here. You can see this filling defect here. So there is transverse sinus thrombosis. This is jugular vein, and this is, if you see, this is jugular vein, and this is jugular vein, and this is extension of the same thrombus, which is extending into the jugular vein, which in the carotid sheath. So this is just an example of complication. Now, this, on the other hand, is a classical exam case. Now, because of time factor, I'm going to talk through a few findings, and then I will ask you, candidate 3. Now, if you see here, this was clinically extremely, the patient had a lot of ear pain, fever, and headache. Now, this is what is happening. We can see opacification of the mastoid cells. We can see the opacification of the middle ear. And if just concentrate on this one and concentrate on this one, and what is the main finding? Over to you, and what is your conclusion?
So axial CT images in bone window and cone down images of the ear, bone window in coronal sections. So there's increased sclerosis of the bone of the
Don't worry about sclerosis. That is just because of the windowing. Don't worry about it.
right. So there appears to be a locule of gas within the temporal within the temporal
Within the middle ear cavity, right?
Yes. Apart from the
middle ear, I'm using the wrong word. Middle cranial fossa, right? Okay.
yes.
Now,
Maybe.
so have you
So that
seen any bony abnormality? What is your conclusion? What has happened, and what will you do next?
I believe there is a bony erosion of the ossicular chain because I can't see the ossicles now. I would like to take this further by having an MR done.
MR done.
Yes.
So now the key point here is, and it is a classical exam case. You picked up the locule of gas very well. This clinical is very revealing, but the key finding is that there is something acute inflammation happening, and even here there appears to be bony erosion. And this is coronal, so this is tegmen tympani. This is what we call tegmen mastoideum, which is superior to the level of the mastoid. There is a dehiscence here. This means there is acute bony destruction. Now, this type of things can happen because of acute otomastoiditis. So, and please remember bony destruction. Once there is bony destruction, you see cortical and trabecular erosion. The complication includes subperiosteal epidural brain abscess, venous sinus thrombosis. You did well when you asked for an MR, and here you are. So, what is happening on this MR? If you can concentrate here, concentrate here, concentrate here, this is that gas locule. How will you tackle it? What will you say? Over to you.
So looking at the MR images, especially in the post-contrast, T1 post-contrast image, there is enhancement of the, I believe, the meninges around the left temporal lobe, and there appears to be filling defect on the MRA images, filling defects of the transverse sinus. So these findings are suggestive of venous sinus thrombosis. I'm just trying to see if there's any collection of abscess collection anywhere within the brain parenchyma. I can't see. Then just looking at the neck. So
That's fine. So you did well, and you were trying to pick up an abscess, which was fine. Good, well done. There is no abscess. Let me tell you the points here. Now, when there is extension of inflammation or infection, what can happen? First of all, look for dural enhancement. When there is dural enhancement, you know that the infection has gone into the dura, and then, subsequently it will go more, into the parenchyma. There is a term which we use, cerebritis, which is a non-specific term. If you see here, there is edema here, but high signal. But as you were trying to pick up, there is no abscess formation. So this, once you see this, you just call it, cerebritis. And you can see the main finding is that there is dural enhancement. There is some high signal, but there is no abscess formation. The gas locule is there. The gas locule has got a bit of, again, dural, meningeal enhancement is there. And then there is sinus thrombosis. This is another classical case which can come in the exam. Now, this case, I am going to go through it myself, and I might ask you some leading question. This is just to give you the concepts of perineural spread of tumor. I believe perineural spread of tumor it's a difficult one, but particularly in regard to foramen ovale, you must know it for your exam. Having said that, this is a very good example. This patient came to our hospital since 2 years was coming with facial nerve paralysis on the left side. And the imaging which was done was CT temporal bone, many a times MR was done by the neurologist. But the key point which everybody forgot, that adequate imaging was not done. Parotid, because parotid lesions can also cause facial nerve paralysis. Now, in this case, what happened was that there was, in the deep lobe of the parotid, there was a tumor. This tumor was adenoid cystic carcinoma. Now, if you look carefully, although this is not classical temporal bone imaging, it is a brain type of protocol. Having said that, you can pick up the findings. So first of all, there is a lesion here, and there is some enhancement. Now, if you look into the middle cranial fossa, the IAM, you can see, cochlea sitting here, you can see this enhancement. So the 7th nerve, 8th nerve, they are enhancing. If you look very carefully where I am pointing out, this is the descending facial nerve, and it is causing enhancement. If you see here, this is the Meckel's cave on right side, this is the Meckel's cave on left side, and there is a bit of enhancement. So this is, something else is happening. If you look carefully, because classically for head and neck, you should have a fat saturated sequence. It is not fat saturated, but what is happening that there is perineural spread into the foramen ovale, which is going here, but not going more proximally. So what has happened is that if you see this picture, it tells you everything. When there is a tumor in the parotid gland, there can be perineural spread through the facial nerve, and it can go up and go into the IAM, just like our case. Similarly, in masticator space tumors, it can go up like this into the foramen ovale. So in our case, what has happened is that, please remember that anatomy-wise, there are some connections to the lingual nerve between the 7th and the 5th nerve. So part of the tumor has gone into the 5th nerve, and from there, perineural spread into the Meckel's cave is visible. This is the coronal of our patient, coronal T2-weighted. And you can see this enhancement, and you can see how it is going into the foramen ovale. This appearance you must remember, and this is an exam scenario. Other tumors can also be asked like this. So this was perineural spread. This is perineural tumor spread around the 7th nerve. Okay, this is your last case, and then we'll go to candidate 4. Now, candidate 3, if you see here, let me talk you through this case. We've got bone windows. We have got some specification here into the middle ear cavity. We can see a bit of, around the jugular foramen. Compare this jugular foramen with this jugular foramen, and there is some soft tissue which is going into the middle ear. When we gave contrast, though the windowing is not very good, but having said that, this is the appearance on contrast, and this is the appearance on contrast. Please describe the lesion and give me your diagnosis. Over to you.
Okay, there are multiple still images of the base of the skull. In coronal axial, there is bony erosion of the jugular foramen, and there is a enhancing soft tissue mass seen within it. So with regards to this location and the irregularity seen here, my first differential will be glomus jugulare tumor.
So what is the glomus jugulare?
It's a type of paraganglioma, quite similar to glomus tympanicum or pheochromocytoma or.
So everything is correct, whatever you are
this particular location.
Yeah, but I am not satisfied with the location. So everything, whatever you told me, is absolutely correct. But you use the word glomus jugulare. This, what part of anatomy is this?
Oh, sorry, tympanicum. Tympanic.
Okay, tympanicum. But
yes,
you are right that it is also involving the jugular foramen. Indirectly, we are just debating the word here to use. It is from the jugular foramen, it is going into the middle ear cavity. So this type of jugular, glomus tumor is known as glomus jugulotympanicum. Are you with me?
yes.
Okay, so good. Let me tell you the concept. Now, glomus tumor is a very, very important case in the exam. Now, please remember the location changes the name of the tumor. So you are absolutely right that just like I was giving you the example of cholesteatoma versus epidermoid, that when it is in intracranial cavity or the calvarium, we call it epidermoid, and in the temporal bone, we call it cholesteatoma. Similarly, in head and neck, we call it a glomus tumor, and in adrenal, we call it a pheochromocytoma. Histologically speaking, it's similar. Now, anatomy or the location changes. What is the concept? This is glomus tumor are chemoreceptor cells along the carotid sheath. So please remember they are in the carotid space. Now the location can be in head and neck, there can be 4 different locations. When it is at the bifurcation of the common carotid artery into internal and external carotid artery, we call it a carotid body tumor. When it is at the jugular foramen, we call it a glomus jugulare. When it is in between the bifurcation and the jugular foramen, we call it glomus vagale. So please remember, because in the carotid space, vagus nerve is also there. When it is just in the tympanic cavity, as in the middle ear cavity, we call it glomus tympanicum. But when there is a large tumor which goes from the jugular foramen and penetrates and goes into, because this is just superior to that, you remember the anatomy, we will call it glomus jugulotympanicum. So this is a glomus tympanicum, this is jugulotympanicum, and this is only tympanicum. These are very vascular tumors. So they will enhance like anything. And another thing is they will cause permeative bony destruction. So classical scenario is that on a CT scan, this is another differential diagnosis, jugular foramen lesion, glomus jugulare, and it is middle ear cavity, and this one is again glomus jugulare. So the key point to remember is 2 points. On a CT scan, look for permeative bony destruction. So look carefully on this case. This is another example. Look at the margin of this lesion and look at the surrounding bone. And this is a classical example of permeative bony destruction. Permeative bony destruction. When you give contrast, it enhances like anything. This permeative bony destruction on a CT scan makes it, because of permeative bony destruction, you can sort of discriminate it with a schwannoma, because there can be schwannomas of the 9/10 of 11 nerve passing through the jugular foramen, and they can also enhance, but they will cause expansion of the bone. They will not cause permeative bony destruction. On a CT scan, that is the key to differentiate it with a schwannoma. On an MR, there is another sign, and we call it salt and pepper sign. Usually, it is seen in a glomus tumor, which is more than 2 centimeter in size. Basic concept is that glomus tumor is extremely vascular. So on a non-enhanced T1 weighted sequence, please remember, non-enhanced T1 weighted sequence, you can see a salt and pepper sign. What is salt and pepper sign? You might see some micro hemorrhages, which are high signal on T1, and you can see filling defects because these are very vascular arteries which have got high flow or vessel, should I say, which have got high velocity flow, which appear as low signal. Salt and pepper sign on an MR, on a non-enhanced T1. Same thing you can see in carotid sheath, as I have told you. And on a CT scan, you can see this bony destruction. Okay, thank you, candidate 3. Is candidate 4 with us?
Hi.
Yeah. Okay. So this one is a mass in the same location. This is an MR scan. This is fat saturated T1 weighted sequence. You can see something here, something here, something here, something here. Can you describe it? What is your differential?
So we've got axial sequences through the lower part of the cranium. And so T1 post-contrast, post-SCAD images, selected sequences. And I can see that within the left posterior fossa, there is an enhancing lesion. And I'm just going to interrogate the other images. So it seems to be in continuation with where you would find the IJV. So I think it's where the vessel would exit the foramen. So I think the left IJV is occupying the left jugular foramen.
Excellent. We are in the same differential diagnosis. So this is a tumor which is sitting in the jugular foramen. What is going to be your differential for this?
So a neural tissue lesion such as a schwannoma or a paraganglioma, but I don't see that salt and pepper classic flow void appearances to it. So I would probably say, because it's expansile and not destructive or osteolytic, I would say schwannoma would be my top differential.
Okay, excellent. Please remember, I've not given you all sequences, but you have tackled it very well, and it was a schwannoma. The key thing is, look at this picture, and you will remember it. Jugular foramen schwannoma. Just like a schwannoma anywhere, it will cause expansion of the bone. It will not cause permeative destruction. So remodeling of bone. Remember that in ribs and spine, etc., you will see the remodeling because of schwannoma. And this is an example from STAT-DX. Look at this, how it has caused expansion. On the other hand, you remember this picture of permeative bony destruction. So this is how you differentiate between the two. And these are the top two differential or jugular foramen maps. There is I will show you this kind of meningiomas in subsequent sessions, but just to let you know, sometimes what happens is that meningiomas, they penetrate the bone, and it can cause hyperostosis. And when that will happen, it will cause sclerosis of the bone. So in the differential diagnosis in your book, you see here, skull-based lesion not specific to jugular. For example, meningioma is there. So just to make a point that this is an example from STAT-DX. You can see this dural enhancement with this expansion here. And these kinds of cases will cause a lot of sclerosis. Classically, the examiners will show you a plain film where there will be sclerosis. And then, when you take it to cross-sectional imaging, it will be a meningioma. Take-home point is that there are types of meningiomas which penetrate into the bone, and then they can cause hyperostosis. And I'll show you these cases subsequently. But it can happen in the jugular foramen also. Okay, this is a tongue. The clinical presentation is abnormal tongue. Over to you, candidate 4.
So we've got selected sequences, T1 stare and T1 post-contrast sequences through the floor of the mouth. And we can see that there's area of increased signal intensity within the left side of the tongue muscles, and on stare imaging it demonstrates high signal intensity, and on the post-contrast study there's no particular enhancement that I can appreciate, though it does look symmetrical, and given that it's high T1 signal on that side of the tongue, it makes me concerned that there is a hypoglossal nerve lesion on the affected side, which would give you muscle atrophy of the tongue and denervation.
Excellent, well done. So, the bar in FRCR exam is going up and up. And I remember maybe about 10, 12 years ago, somebody who was my student, he got this kind of a case in the exam. So this is a case of tongue atrophy. And there is a concept of what we call denervation. So what will start is, I'll talk you through the case once I give you a bit of theory behind it. What happens is that the 12th nerve, it supplies the intrinsic muscle as well as the extrinsic muscle of the tongue. Now, if a patient presents to you with atrophy of the tongue, The first thing is that you will tell the examiner that I want to scan the whole neck till the base of the skull. Anatomy, remember the anatomy that hypoglossal canal is sitting next to the carotid space. So there might be a lesion at the base of the skull, and which can cause motor denervation. And in this particular case, there was again a glomus jugulare, which was causing it. Because the hypoglossal, as soon as the 12th nerve comes out of the hypoglossal canal, it is in the carotid space. So, of course, this was an infiltrative lesion which has caused its denervation. Now, this is the concept. So, what will happen that you can divide the denervation or the effects of denervation into acute, subacute, and chronic stages. The definition of acute is less than 1 month. Subacute is 12 months to 20, should I say less than 12 to 20 months. And this chronic is more than 20 months. In chronic, what will happen that there will be fatty atrophy, and which will be high signal on T1. There will be no enhancement on or no edema. But in acute, what will happen that there will be, acute enhancement, acute edema. Subacute will be somewhere in between. So our case is somewhere in between. If you look carefully, there is high signal on this T1, means fatty infiltration. And then on stir, there is a bit of edema and maybe a bit of enhancement. So it was subacute. On the other hand, look here, these are two different cases. This is a CT scan, and even on CT scan, you can see atrophy. And this one is from a stir sequence, you can see a lot of edema. This is another case which presented with, the clinical, when they saw the tongue, this was their clinical. They said that meningioma of the tongue ? And what we found is that there was high signal on T1 weighted sequence. This is stir, just a faint edema, just a bit of enhancement. So this was subacute. In this particular case, there was nothing no lesion was identified. So this can be a potential exam scenario. The examiner can show you this kind of case, and you will ask for rest of the imaging. You will go through it, and you might find a tumor or a lesion to explain the findings. But if you do not find a lesion, then you call it idiopathic hypoglossal palsy. Remember this concept. This is another patient. This is not this patient, but just to make a point, this is what happens. Okay, candidate 4, over to you.
So we've got a 42-year-old male with a history. We've got a 42-year-old male with a history of 6 cranial nerve palsy. So I'm just going to take a moment to interrogate the selective axial and coronal images on CT. So there is an area of low density within the left petrous apex, and when you compare it to the right side, it does look quite asymmetrical. And with that history makes me think about petrous apicitis and cranial nerve 6 sort of.
Can I ask you if your observations are absolutely correct, but there is one finding. If you see here, this is the petrous apex on the normal side, this is the abnormal side. And the abnormal side is what is happening to the bone.
Oh yes, so it's osteolysis and erosion of the bone.
Before that, because please
and
remember,
expansion.
Expansion. That's the key word, isn't it?
Yeah.
So yeah, osteolysis or erosion can happen just like that. So this is totally, what comes to your mind then? This is expanded like anything.
So this would be in the region of where you'd have the ICA and the carotid canal. So it does
So
make me think.
let me, you see this thing?
Yeah.
This is the,
So either a lesion that's within the
okay.
carotid
Do
sheath,
you,
or
do you want me to show you something?
an MRI or an angiogram.
Okay, so I've given you an MR.
Okay, so we've got a right-sided T2 hyperintense lesion that's expansile, and on the axial sequences, we can see that it's disrupting the bony anatomy.
Okay, madam, let me give you a hint. The key sequence to make the diagnosis is this T1. What is the signal? That is the hint from me.
So it's the same signal as fat.
Yeah.
And so it's a fat containing lesion. And
so you see there is an expansile lesion, means it is long standing. It has got this high signal. We'll come back to this. Why is it high signal? And it doesn't look malignant or infiltrative. So this is an Aunt Minnie case. Hint.
so a fat containing lesion in that location, which is expansile.
Fat containing, you know, you
or-
can take it with a pinch of salt. The word, there
Okay.
will be some fat, but
So, I mean, in that location, or maybe, sorry, maybe it's just sort of blood.
blood, excellent.
So an aneurysm,
Okay, so let me take
thrombosed
over.
aneurysm.
Okay, let me take over. It's an Aunt Minnie case. So this is a cholesterol granuloma. What is a cholesterol granuloma? Basically, the pathology is, or the pathophysiology is, cholesterol granulomas can be in the middle ear cavity mastoid, or they can be in the petrous apex when it is, aerated, etc. Basic concept is that, there is a vacuum phenomena, there is inadequate aeration, and gradually what happens, there is a chronic inflammation. Just remember that. It's a unique type of inflammation. This inflammation causes new blood vessels, etc. Very chronic, and I read a study in literature way back where they had documented a cholesterol granuloma developing in 22 years. 22 years, so because they had serial imaging. Now, what happens is that it keeps bleeding within the lesion, and so part of the high signal is hemorrhage. Part of it is cholesterol crystals. That is the concept, and it will cause expansion. So it's a unique type of inflammation, chronic inflammation. The radiology is Aunt Minnie radiology, and it will cause expansion. Now, what will happen that on a T1 weighted sequence, it will show you high signal, partly because of methemoglobin and maybe because of cholesterol. Mostly it is because of methemoglobin. Now, when you give contrast, you cannot see any enhancement. But having said that, on a T2 weighted sequence, at times you might see a hemosiderin rim, which is chronic hemorrhage. On a post contrast, sometimes you might see a subtle granulation tissue, which is enhancing. Key point is, it's an Aunt Minnie, and there is nothing else which can cause this. Please remember that aneurysms, there is no concept of aneurysm of the carotid canal like this, because an aneurysm cannot expand the carotid canal. It's a very tough bone. So this is a cholesterol granuloma, and this is from your book, books, well-defined expansile. So this is an exam case, by the way. This is another cholesterol granuloma. But the key thing, this is not very expensive, as expensive as the one which I showed you from StatDX. But the key finding is look at this T1. And if you look carefully on this T2 weighted sequence, you can argue that rim is showing hemosiderin. Another example from, I think, American College of Radiology. So it is causing this huge expansile lesion, and this is expansion, and you can see that there is a bit of a hemosiderin rim, cholesterol granule. So this is the last case of the day now. Candidate 4, are you with us?
Yes.
So this is the last case of the day, and maybe you already know the diagnosis, but the thing is that because we are doing petrous apex, I am showing you a scan which was this male patient presented with purulent porphyria with fever. So we can see that there is a lot of inflammation, opacification of the mastoidal cells of the middle ear cavity, etc. And this is the petrous apex. You don't see much there on this CT scan. And you can see a bit of aeration is there, but these are also opacified. This patient presented 5 months later with diminished, so he was clinically, he was dealt with antibiotics, got better. After 5 months, presented with and symptoms of left eye with 6 nerve palsy. What comes to your mind with this clinical before I show you the scans?
So I'd think about petrous apicitis with Grada-Nigra syndrome, where you get a 6th cranial nerve, abducens nerve palsy.
Excellent, well done. What are your comments on this flare sequence?
So I know that the abducens nerve supplies the lateral rectus muscle. So if we did
can you
yes.
describe your findings? Can you describe it on the flare?
So on the flare images on the left side, we've got a high signal lesion within the region of the left temporal bone. And I'm just looking for, so there's also some increased signal within the anterior portions of the temporal bone on the top left image.
Yeah. So which portion is this?
Yeah, so it would be the petrous portion.
Yeah, and this is the clivus, and so this is unusual because we had done a brain type of protocol, so there was a flare. But the point I'm making is that even on a flare, because it is fat saturated flare, you can see something happening there. Unusual to see that. You can compare it from here. Now this is post contrast. What's happening?
So in the left side, we've got high T2 signal high T1 post-contrast signal and enhancement at the left side where we saw the lesion within the left cranial, anterior cranial fossa, anterior middle cranial fossa.
Actually, madam, where are we? What is this? What is this? What is this?
So we're looking at the left region of the left cavernous sinus with the ICA.
Excellent. Excellent. So if you go to this T2, even here, though it's not completely, but there was a slightly different signal here, right?
Yes, so I would think about cavernous sinus thrombosis and pus or thrombus within as a complication within the cavernous sinus, as a complication of the inflammation within the petrous apex.
Excellent. So if you see here, then we can see on this, cavernous sinus thrombosis here, and I will show you cases. I think maybe next session, where please remember that there can be secondary thrombosis of the ICA, and that is known to happen, and that can occur. What happens is that when there is cavernous sinus thrombosis, it's common sense because there is infection there. that infection will penetrate the wall of the carotid artery, and then the patient will present with stroke, complete occlusion of the carotid. So look for that also. So that should be your pertinent negative, that I can see the normal signal void of the internal carotid, but I can see this enhancement. There is cavernous sinus thrombosis. Now, some of the other that was done, and I believe there was some doubts on the, and just to make a point, nobody is going to show you a PET for this, but it was showing, this thing was on fire on the PET scan. So you dealt with very well, where this is the anatomy, and where you can see this is the canal, Dorillo's canal, 6th nerve. So 6th nerve can be involved. 7th nerve, and you remember the anatomy, because not 7th nerve, 6th nerve, and the other nerves which go into the cavernous sinus, they can be involved. So the definitions can be variable. If you see here from your book, uterus appendicitis, and this is the syndrome, retroorbital pain, mitral rectal palsy, plus otitis media, plus minus cranial neuropathy, which now 5 to 8 can be involved, because the infection, as this is the IAM, this is not far away, so this can also be involved. So this was uterus. Okay, thank you very much.